Thank you, sir.
Good afternoon, friends. It is Friday afternoon, and we are back after our 76th episode where we celebrated the Platinum Jubilee of FFF webinar. Established in May 2020, we've been doing this webinar series on every Friday. We had actually so far 85 Fridays, and we have completed 76 episodes. So this is the 77th episode. Barring national holidays, which had fallen on Fridays, we've been doing this program on a regular basis. So we've completed 12 series, and we are now in series number 13, where we have discussions about quality matters and how we can move on to continuous quality improvement. So that is the theme we are exploring. And we had a talk about quality in patient care services on the 7th of January. That was the first episode for this year. And 76th episode where Dr. T.S. Ravikumar, who was the former director of JIPMER and also former vice chancellor and medical director of Sri Venkateshwara University, Tirupati, and he is also the president of AIIMS Mangalagiri. He spoke about his involvement in quality in patient care and his journey he has undertaken and what changes he had brought in. So that is a just recap of this. And we have another very interesting episode today. We are again exploring this theme of quality, and we are talking about how quality in diagnostics and laboratory services can be improved. And we have with us Dr. Hariom Sharma. He's the professor and head Department of Biochemistry, and also he is the director of lab services at Government Medical College, Bhavnagar, Gujarat. So that he'll be the speaker for today. And before we start, I'd request our Dean Sir to give the welcome note. Over to you, Dr. Koto.
Yeah. Thank you, Professor Mahalakshmi. Very good afternoon to all the participants and the main resource person for today, Dr. Hariom Sharma, and my colleagues, Professor Bhatt, Professor Mahalakshmi, other faculty members and other participants. It's indeed, we are marching towards the 100th episode. We are very proud and excited about it. We crossed 75. This is the 77th one. And I, on behalf of our management, on behalf of our Chancellor, I consider it a privilege to welcome Dr. Hariom Sharma, who has visited our institute some time back. And here is a man, and a right man, who has pioneered the quality, in the especially lab services in the state of Gujarat. I was very happy to hear that, and we are indeed fortunate to have your first-hand experiences on this occasion. And in this era of competitions, in this era of accreditations, in this era of the quality, quality assurance, quality sustenance, and quality improvement are a way of life. Why only a laboratory? In every walk of life, it is a must. And without that, it will be quite difficult to survive and make a mark of your own. And I already said with the speaker that we are amidst the NAC accreditation, we are amidst the NABH accreditation, and he is talk about the laboratory accreditation. Certainly is going to help us quite a lot on this occasion. So I once again take this opportunity to welcome Dr. Sir Hariom Sharma to this Triple F prestigious platform to share his experience. Thank you very much once again.
Thank you very much, sir. Now to introduce Dr. Hariom Sharma. He is a PhD holder. As I already said, that he is also not only the professor and head of biochemistry, he is also the lab director for the Government General Hospital, Bhavnagar. He is the NABL director in the Government Hospital Labs for Medical Colleges in Gujarat. So that is where we actually interacted with him and got him into this platform. He's got a membership in American Association of Clinical Chemistry, so which is a very rare honor. He is also a member of Sickle Cell Disease International Organization. He is in the Indian Academy of Biomedical Sciences. He had acted as president also for that. So he has received the honor of being the first NABL accredited government hospital lab among all medical colleges in India. I think that speaks of his commitment to the cause and why he is the resource person for today. And he has been awarded by the government of Gujarat for his outstanding contributions in the field of healthcare quality improvement. As all of us clinicians agree, right? Our clinical diagnostics form only maybe 25 to 30% of skills as of now, but the rest of it we require from our diagnostics friend, be it microbiology or pathology or radiology, to complete the clinical picture. So he has been aptly awarded by the government of Gujarat. He has presented multiple research papers and posters in national and international conferences. In fact, his students also, many of his students and postgraduates have also taken this honor. And he has organized many state level CMEs and workshops, especially on quality and NABL. And in fact, we could get his contact details from the NABL workshop, which he had recently organized. So that is how he again got him. So, ladies and gentlemen, I present to you Dr. Hariom Sharma, and he is going to talk to us about how we can improve quality, especially in the laboratory and diagnostic services. Dr. Sharma, the stage is yours. You can talk. And before we start, just a small announcement. We are going live on YouTube, and this program is recorded for academic purpose. And also, I'd request all the participants to keep themselves on mute mode and use the chat box for communications with us. Over to you, Dr. Sharma.
Thank you, madam. Thank you so much. I think the presentation is there.
Sir, you need to start sharing, sir, because I had to make it.
Okay, now
Yeah.
we can see it.
And sir, full slideshow mode, sir.
Yeah. Yeah.
Yeah.
Good afternoon,
Yes,
one and all. Very warm welcome from Bhavnagar. Before I start the present topic of discussion today, I would like to thank Dean sir, Professor Bhatt sir, and Professor Mahalakshmi madam for giving me an opportunity to discuss whatever little knowledge I have on the laboratory quality management system and the topic of today's discussion. So I want to thank you from the bottom of my heart so that you allowed me to speak on this very prestigious platform. And secondly, this topic selected is very, very important for the entire laboratory management system. But it is again a very challenging thing where, when you have to deliver a talk where you have to explain quality. So let's see how we begin. What are the objectives of this discussion today? How we can define quality. Then what are the fundamentals of quality management? What is the term known as total quality management, quality system and its assessment, then introduction to the quality control, and how to implement it in practice. What are external quality control programs? And finally, the new quality initiatives. If I ask you, why this term quality is in the talks of medical management system, it was not there. What I could learn so far, quality was basically for a product. When you design a product, you talk about its quality. We ask ourselves, when you are going to buy a product, may it be a simple car. If you remember, many of you might not have seen Ambassador model. But over the period, Ambassador is nowhere. It is not existing. So we say quality of a car, quality of a cell phone. We have seen the journey. So my quality the medical services are not basically a product. But later on, it was realized that medical services again are, in one way or the other, delivering certain quality-driven services. So how we can introduce the concepts of qualities to the healthcare management system? Earlier it was the treatment, but now it is called healthcare management. So it is not only one doctor or a one person or one or two. It is a team of so many experts which deliver the contents of the healthcare management system in totality, and we call it the medical management system. So let's see how to explain this. You see this scenario. This is a quality product sold in a wonderful air conditioned showroom. It is a showroom for the shoes. See how beautiful it is. So when you go and you buy a product for your feet, you look for the quality. This is second scenario where we see again the quality. If any one of you can give the response, what is this? Very quickly, if you can identify. Let me tell you, this is a hair salon. What a beautiful hair salon. See the cleanliness. So what about, they are also providing the services. In the previous picture, this is a product. But in this picture, it is a service driven thing. So we again look for the quality when we go to a salon. And now you will appreciate this slide. What is this? This is the quality of a product that we consume every day when we say it comes to nutrition. So, this particular picture embarrassed me so much. What is the scenario and the mindset we have when it comes to the quality? If you compare these three pictures and you see what are the effect of these products on our health, then you will find hardly they are all are looking towards the aesthetics. But what is this? This is nutrition. Whatever vitamins, minerals, good food you talk about, where it is sold. If this is the place where it is sold, you can remember or you can understand where they are stored when this vendor is selling it. So from this point, our journey begins for quality. So it can be defined, it is a sum total of all characteristics of a product or a service. Usually it started in the industry. The product of quality and the quality concepts were initially introduced in the manufacturing sector where a unit was actually producing some product and bearing upon the utilization of the product or service, the entire satisfaction of consumer that deals with the quality. Now, conformance of the requirements of users or customers and their satisfaction. So there are two terms in this slide. One is conformance. Which are the elements or which are the policies or procedures you have actually enlisted for your system? If it is followed, then it is a conformance. And what is the purpose of conformance? That end product or the service should bring satisfaction to their customers or to their users. So I could find out these five elements I have selected from various information and literature that quality should be acceptable to all. It should be achievable. Sometimes I made a goal which is not at all practical. So we have to see that quality should be achievable. Then again, there is a point, it should be affordable. Though it is achievable, it is acceptable. If it is not as affordable, you cannot go away with it for a longer period. Then you have to sustain it, for the entire period, whatever service or product you are manufacturing or rendering. Then quality should be measurable. How to measure, So these five key elements, we have to see the quality of a laboratory system. But in a hospital setup where we have outpatient department, we have indoor patient department, we have operation theaters, we have emergency services, we have different ICUs, all together, though they are separate units, but there is one central unit in the hospital management, that is the laboratory. Every single patient coming to a hospital or a clinic is always had a prick, and its blood sample, its urine sample, or various body fluids or tissue samples are always sent to a laboratory. So what is common to every patient and a doctor in the healthcare management system? His connection to a laboratory. All doctors are connected to the laboratory system. So they have to mutually understand that what are the requirements of the patient and what are the requirements and what are the expectations of the clinicians and how the laboratory has to fulfill those requirements. At the same time, the healthcare management system should also understand that how laboratory works, what are the limitations with them, and how together they can work and make an achievable good. So there are the purpose are very clear: to reduce morbidity, reduce mortality, and to reduce economic losses. When you reduce all these things, you always have a good creditability in the healthcare system. So what they normally say, if you are delivering 10,000 good quality results, but even one poor quality result will never take care of your 10,000 good deeds. This we have to remember always. So quality in lab is what? It is a laboratory specialist, clinicians, and public health physicians. They all are, mutually responsible for this work. So why what we call errors? When on one hand it is the quality work, quality services. So there are three things broadly we can say it is the man, machine, and the material. Three things are there broadly in a laboratory system. We have analyzers, we have reagents, we have control material. Over and above, we have technicians and our experts, biochemists or pathologists or microbiologists who take care of the entire laboratory management. But when there is a disagreement, when there are errors, what happens? So what is error in a measurement? There is always a term called true value. True values are, they are never achievable. We cannot get 100% true value. Then the second term came in the laboratory quality system, that is accepted true value. What is the accepted true value? It is the value approximating the true value. How close you are to a true value. That is the wonderful thing. That is should be the target of the labs. And the difference between the two values should be negligible, should be minimum, bare minimum. And then finally, the term which always attracts me, which always I want to hammer every laboratory personnel to understand the error is it is the discrepancy between the result of a measurement and the true value or accepted true value. Let's see how the blunders do occur. See, this was the first case ever which went to the Indian court, and this lady, both these husband and wife, they were NRIs from West Bengal. They visited India, and the wife of this doctor, Dr. Anuradha, she contracted toxic epidermal necrolysis while in India, but she was misdiagnosed by the hospital pathology laboratory. And due to that, the overdose of steroids were given to this lady and she lost her life. Dr. Saha, he fought the case of his wife over the long period of time, and finally court agreed that there was a gross negligence in the laboratory report, and the hospital and pathologist were fined 6 crores of rupees. This was the first ever biggest case and the battle won by a patient. So wife Anuradha, Kunal Saha's wife, she lost due to medical negligence. We are emphasizing on error and how an error can take somebody's life. This is one example. Second example I would like to quote here is the Ahmedabad lab called Supratech. Because it was published, so I have chosen to take the name of the lab also, and it was published in the reports in the newspapers everywhere, so it is a non-fact. Even the patient name is also not hidden here. It was published in the newspaper, so it is from the news and it is a authentic source. So this was a case of thalassemia. The wife was thalassemia minor. The couple got tested before marriage and before they wanted to go for the baby, and lab gave them the report that the husband is normal, but the baby was a thalassemia minor. They again got tested because after the lab report only they planned their family everything, and they realized that there was a gross mistake by the laboratory in giving the reports. They sue the lab and court fined the lab with 18.5 lakhs damage. See, financial burden is one thing, but the burden on somebody's life can never be repaired. You cannot repay. So a child born due to the laboratory negligence or medical negligence is again a burden to the family and to the society. And what is the fault of this child? Okay. So all these points trigger very, very crucial responsibility of every personnel working in the laboratory management system, surrounded by the healthcare management system in total, to deliver the total quality management in the healthcare delivery system. If we look at the introduction, in 1965, the quality controls were published, and now only one part of the total laboratory control program. Quality control is seen as one part of the laboratory control program. Quality includes total quality management, which is an activity to improve patient care. What is total quality management? To improve the patient care, it works to detect deficiencies and subsequently correct them. So every moment, what we try to do, we see whatever policies, procedures, standard operating procedures we have framed, how we are implementing them in our system, and what is the disagreement from our written procedures to our practices. And then we have to see non-conformities, do the root cause analysis, and then correct them so that we maintain the quality. Continuous quality improvement, CQI, or performance improvement. So we have, this cannot be a one simple thing for a day or two or for a month or a year. As long as you are working in the laboratory management, as long as the labs are giving the reports, they have to be on their toes. So we call it continuous quality improvement. Then comes the quality assurance. Well, how you give assurance, in normal terms, I assure you this will be done. This term we use. But in a healthcare management system or a laboratory management system, we use quality assurance. What is that? External activities that ensure positive patient outcomes. It measures what a lab can do to improve reliability. Your results should be reliable. You can trust the results at any point of time. So this is an assurance. That's the talk of the day. So basically there are three principles of clinical lab: quality management, quality assurance, and the control of the quality, normally called quality control. What it says fundamentally, the management says total quality management of clinical laboratory, control of pre-analytical variables, control of analytical variables by doing external quality assessment and proficiency testing programs. So a laboratory is divided, or the functions of a medical laboratory are into three phases: pre-examination, examination, and post-examination. So work of a laboratory basically starts when a test is requested. And who requests the test? The clinicians. So patient goes to the clinician, a test request form is filled, then the patient comes with that test request form to the lab, then sample is taken. Before it is analyzed, all these areas are pre-analytical. Then we have the examination phase or analytical phase, and then post-examination result. So the journey for a laboratory work begins from a test is requested to the report reaches to the end user, clinician. So let's see how we explain the total quality management. Total quality management refers to total quality control, total quality leadership, continuous quality improvement, quality management, science, or industrial quality management. So these terms are quite overlapping with the industry, and same is used by the healthcare organizations. Quality system in healthcare organization is evolving. Public and private pressure to contain costs are now accompanied by pressure of quality improvement. So there are two things. We have to see that how we can use the best technology, how we can have the best quality, but at the same time, we have to maintain the affordability as well. So these challenges are manifold, and ultimately we have to make a balance. Elements of the laboratory business quality management. This involves quality planning or QP, quality leadership, then quality laboratory practices, quality control, followed by quality assurance, then followed by quality improvement, and then quality indicators. So if we go to this sequence, ultimately anything begins with a planning. Then you have the leaders who plan it and then execute it. Then the entire management system began to practice those quality things. And how it is actually measured? It is measured by running the quality controls, which can be internal quality controls and external quality control. And their outcomes of these practices will assure the quality at all level. And whenever there are disagreements, we do the root cause analysis and we do the improvements. And this all is achieved by identifying certain quality indicators. So what are the quality indicators in a laboratory system? In all these three different phases, pre-analytical, analytical, and post-analytical phases, there are different quality indicators, and each lab has the flexibility to pick and choose the most suitable quality indicators for their own system to assess their qualities on day-to-day basis, on monthly basis, and then periodically review them. Nothing new in this slide. Ultimately, we are talking about the 5 components: quality planning, quality laboratory practices, quality control, assurance, assessment, quality improvement. Things like that are always crucial to the laboratory. And by doing these practices, ultimately we can implement the total quality management in the laboratory system. The 5Q framework, as the laboratory quality is managed objectively with the scientific method. So this is a plan, do, check, and act. This is the cycle which continuously keeps on going as long as the laboratory is working. So we cannot make any break in this chain work. The universal principles of total quality management are: focus on the customer, management commitment, then training. Training is for what? For the manpower. So we say there is man, machine, and material. So for man, how we can improve the quality? By training them again and again, by assessing them, then retrain them, and keep on checking their expertise. We keep on improving their level of expertise, and with the newer techniques coming up into the functionality and so on. Then the process capability and control, measurement using quality improvement tools. Cost must be understood. Cost is very important. So quality is what? Conformance to requirement. What are the requirements? If you meet them, you are doing the quality. Quality costs. So what is cost of conformance plus cost of non-conformance? They are both the things, they go hand in hand. It is never possible for any system to be 100% error free. So by mistake, if the fully auto analyzer
Sir, you are muted.
okay, it's okay now.
Yes, sir. Okay, sir.
Yeah.
Thank you, sir.
So this cost of conformance is very important, but if we keep on doing non-conformities, it will also add to the cost of the quality. So there are two areas: cost of conformance, cost of non-conformance. If there are internal failure cost and external failure, say for example, for the internal failure cost, scrap material, rework, we have to redo, and we have to repeat the runs. So these are the things that they suit the example of internal failures. Whereas external failure, that are the complaints. So the customers are not satisfied with the services, with the report, and then again there is a repeat of the test request. So this will add to the cost. Similarly, if there in normally maintain the conformance, we have to do the training. Training always cost, like whatever we are doing today, it is costing. So we are doing a training. Then in the laboratory, we have to do calibration and maintenance. So there are a few simple examples to show that how the cost towards quality is taking place. And then appraisal cost. When you want to invite some third party to audit your system and to grade you, then it is inspection, quality control cost. So quality is again a costly affair, but we have no choice. So what ultimately is improvement in quality leads to reduction in cost. This is the bottom line. But if we have a good quality management system in place, it will definitely reduce our cost, our burden, and mental stress. Quality is a degree of excellence. So in a laboratory system, we have to achieve it by implementing internal quality control program in place, and second, by doing quality assessment. And these assessment in India, we have certain bodies like National Accreditation Board for Testing and Calibration Laboratories, and some other assessment bodies. And then ultimately you assure the quality. That's the aim of our services. So there are two terms we normally say in a healthcare system of the laboratories: quality control and assurance. These two things we should very clearly understand what is the difference, because the terms keep overlapping each other. So, but there is a good difference amongst these two terms. Quality control refers to the operational techniques that must be included during each assay run to verify that requirements of the quality are met. So how we will check our quality requirements when we are doing the patient samples? By running the internal quality controls that we do every 12 hours periodically. This is what the standard Indian standards of laboratory quality control 112 says. So if you are having a 24-hour lab, every 12 hours you should run 2-level control at least. And this is how you check your quality. But assurance, it refers to all those planned and systematic activities to provide confidence that the result given out by the laboratory are correct. So you are assuring yourself, you are assuring to your customers that the results are most close to the true values. So aim of quality control is simply to ensure that results generated by the test are correct. However, assurance is concerned with much more. It is having a very broader view and the bigger domain also, that the right test is carried out. Pay attention to this point. Right test is carried out on the right specimen. So it tells you that specimen should be correct. Then right result is generated. Once the data is generated, very crucial part comes of its interpretation. So data is followed by the right interpretation of the data and delivered to the right person. So it reaches to the person it belongs in a stipulated time. That is called turnaround time. Right time means what? For me, taking a sample and analyze it and generate a report can take 5 hours or 6 hours or 10 hours. So what is the right time? So in the International Standard Organization 15189 2012 standard for laboratories, they have talked about how to define quality indicators, and one term is turnaround time. So right time actually in the broader aspect starts when the test is requested to the result reaches to the clinician or to the end user. So this is one broader application of the turnaround time. And second part of it starts when the sample is drawn to result is authenticated. So this is the inner part of it. So we have to take care of all these right things. There are few rights: right test on right specimen, giving right result, providing right interpretation to the correct person in stipulated time. This is how we say quality assurance in laboratory. Assurance have these different segments of the lab: pre-analytical, analytical, and post-analytical. Say a few examples we can take in the pre-examination as a specimen collection. Very, very important part. So far our knowledge, our research data and experience says that maximum error in sampling occurs. So pre-analytical phase actually contributes towards 60 to 70% of the errors. And this is not directly under the control of the laboratory personnel. It is the duty of the phlebotomist. So how trained your specimen collectors are, your phlebotomist, how carefully they draw the sample, they preserve it and transport it, so that the quality of the specimen and its integrity is not at all compromised. So These are the pre-analytical domain. Second is, in the analytical phase, we look for the result accuracy, clerical errors, analytical errors, and assay repeat rate. How many times we are running the controls again and again, how many times we have to repeat the patient sample. So actually internal quality control is also treated in analytical phase. Once the data is generated, post-analytical phase is how to authenticate the patient result, how to analyze the data and give the interpretation. Proper reporting should be done. Record of the report should also be kept, and things like that. So this diagram will tell you the three phases. Pre-analytical, that the patient is pricked, sample is collected, transported, then personnel doing the quality control part, testing the samples, then record keeping and reporting. So pre-analytical and post-analytical phases are there. Quality control, tactical procedures. Now we have talked so much about different domains of the quality control. So control of pre-analytical variables. Ultimately, we have seen there are many variables in any process. So all these three phases, which are those variables which contribute maximum towards the error? We have to control them first. You know, in our family, what we say, this boy is notorious, take care of him first. So what is the most notorious thing in your system? You have to control it first, gradually going down to the system. And all the variables need to have a check and balance. So controls of pre-analytical variable, control of analytical variables, and control of analytical quality using statistical methods and control charts. So we have internal control, then we plot the Levy-Jennings charts, we analyze them, we see the random errors contributing towards the non-conformity, we analyze the systematic errors, things like that. So many things to be done as far as controlling the variables are concerned. So first, let's see lab testing process and their potential errors. What can be the errors when we are doing the test ordering? Sometime inappropriate tests, then handwriting is not legible, wrong patient identification. So these are few examples of error that occur during the test ordering. Then specimen acquisition. What are the errors that can occur here? Sometimes the phlebotomist, like in my hospital where we have the OPD of 200 to 300 people in a day, and IPD samples coming to the lab varies from 200 to 300, or Ahmedabad hospital having 10,000 samples per day. Such big labs are there. So the number of samples may be whatever, a small number or a huge number or a big number. So there are possibilities that the under pressure or under certain another variables of the staff, somebody is sick in the family, there are financial burdens or so many challenges to the person as well. So there may be chances of incorporating more errors. Then incorrect tube is selected, incorrect patient identification has occurred, the volume of sample in our laboratory system, when we did the audit, and we realized that most error occurs when we are doing the sample for CBC, because it is a pre-volume tube, and either sometime it is under diluted or over diluted. Sometimes blood is crossing the mark on the tube. So from 2 ml, sometimes it becomes 2.5 ml or 3 ml, or sometimes it is 1 or 1.5 ml. So because CBC is done in a kg EDTA tube, so that material which is coated inside either sometime under dilute the specimen or over dilute. So these are the volumetric things but need lot of care. Then invalid specimen diluted and hemolyzed, collected at the wrong time, improper transport conditions are this couple of important variables here. Then what are the errors in analytical phase. Instrument not calibrated correctly. Instrument calibrations are very important. Then how the mixing of specimen, because all labs cannot afford automation. So many small labs, they do semi-automated work on semi-automated analyzers, manual working. So these domain are quite crucial. Then incorrect volume of specimen. We never look for the interfering substances present, because in couple of cases, they say for example potassium. If the sample is even partially hemolyzed, the values are going to be incorrect. Even many labs are still performing glucose estimation in the serum sample. The sample was taken long back. They don't use the fluoride bulbs, or they don't use the appropriate vacutainer for that. And because the RBCs will consume glucose, so you bound to get some incorrect value for glucose. So these are a few areas that adds to error in the analytical measurement phase. Then the test reporting. Wrong patient identification, report not legible when the reports are handwritten. Sometimes creatinine we have seen, now we have moved to computerized system long back, but sometimes we have seen report it was 1.5 milligram per deciliter creatinine, and it went 15.0. And there was a big blunder. And we have to apologize, we have to accept our mistake. So another condition here is, now the work has begun in some developed countries, how to accept medical errors, how to learn from our errors, and see by doing the root cause analysis how we can control the errors. So such transcription errors do contribute in the wrong reports. Then test interpretation. When a lab report sometime under the asterisk says that this specimen was performed in a hemolyzed sample, please correlate clinically. Sometimes it is overlooked. Sometimes they say bilirubin, but there was interfering substance, there was lipemia. All these things can add to the inaccurate results that need to be correlated. Then specificity of the test not understood, precision limitations not recognized, analytical sensitivity not appropriate, and previous value not available for comparison. This is sometime it plays a
He has gone out of connection.
It's still there, sir, but some problem with the internet.
His picture is not seen now.
Calling, sir, 1 minute.
I think the current might have gone off or something must have happened. Internet error we can add now.
it is coming.
Sir, we can hear your voice. Yes, you are back. But slide, we are not seeing anything, sir. Just showing your sharing screen, but we are not seeing the slide.
Okay.
Sir, you can stop sharing and reshare, sir.
Okay.
Yeah.
He has
Again,
to
now
open
you
the
can.
slide again.
Yeah.
Okay, it's come now?
Yes, sir. Yeah. Sir, actually, we were in the previous slide when you got disconnected, sir.
Okay.
The interpretation, the previous slide, the purple one.
Yeah.
We were here, sir.
So
Yeah.
these are the things, previous value not available. So as I was saying that in case of the patient on dialysis or certain medical intervention where we have to carefully monitor the previous reports, it plays an important role, things like that. And how to control these errors. In case of patient identification, we can use barcode techniques to reduce such problems. Then we need to improve the turnaround time. As I said, delayed and lost test requisition, specimen or reports can be major problem for labs. So we have to always stick to turnaround time. We have to divide turnaround time for routine patients, normal patients, for ICU patients, or emergency samples. So these turnaround time always vary from case to case. Then how to control these errors in case of transcription in the pre-analytical area. Instead of manual data entry or writing everything, we can now move towards computerization or the barcoding system. Then we have to again start learning good patient preparation techniques and the newer availabilities of such procedures. The lab must define instructions and procedures in compliance with the instructions, and a monitoring also is very crucial. Then specimen collection is sometime affected by prolonged tourniquet application, blood collection from an arm which is having the IV infusion running. Sometimes it leads to blunders. We have seen the glucose value in a patient coming to 2000 milligram per deciliter and so on. So having a dextrose and it is not properly withdrawn sample. Then hemolysis during blood collection is a challenge. We need to learn those things and master the techniques to have the zero hemolysis in sample collection. Then clinicians should be encouraged to report clinically inconsistent results. Then the factors influencing analytical variables. Analytical phase, which involves quality control, also ultimately give a certain level of quality assurance to our results. So it has the gray areas where the reagent stability is very important. Then integrity of the sample also important, and efficiency. So it should be stable, efficient, desirable quality, continuously available, and should be validated. So it again attracts so many other things. Due to the limitation of time, we cannot touch upon all these points. Then equipment reliability, we have to see that equipments are function properly. Then specificity and sensitivity of selected test we have to see. Then procedural reliability using standard operating procedures, everything has to be documented. Now, whatever SOPs you derive for your own system, there is a flexibility in ISO or in the CAP, College of American Pathology, or the UK accreditation programs. There is a big flexibility as per the policies and the availability of instrument, manpower, and regional conditions. A lab can design its own SOPs. But once you design something, a scientific document need to be followed. And when there is a disagreement, be very honest in accepting that there was a disagreement. Do the root cause analysis, control the non-conformities, and move ahead. The documentation is very crucial to look upon in our scenario. Then assessment should be there. In our laboratory, in day-to-day practices, we see the daily non-conformities. Suppose the person comes, he has to clean the equipment first and see the temperature stability. He has to take out the reagent from refrigerator and see the room temperature is maintained. He has to take out the frozen control material and see they are properly thawed and they attain a normal temperature before they are put into practice. So all these things are a day-to-day practice that we have to keep on monitoring round the clock. Then proficiency of the personnel is very crucial. We have to educate them. A class 4 staff, the housekeeping staff who is cleaning the toilets, who is cleaning your floor, your doors, your environmental conditions are maintained by him. So starting from the bottom of the pyramid to the top, education plays a vital role. Training and retraining is required. Aptitude we have to generate. We have to see the competence by doing the MCQ test, by giving the split samples, and we have to see their commitment and create this quality of commitment in our staff member. Adequate number of staff should be there. Continuous medical education practices should be there. Then supervision and motivation is the key role. You know, when every day you are coming to the same atmosphere where you are surrounded by complaints, how to ensure that your staff is motivated? I think I give a big importance to this particular word. So all these together make a change. Then we have the control of analytical variables. We know all about methodology and so on, not talking much on that. All these things are very important. The quality of water, calibration, volumetric glassware and pipettes, stability of electric power is crucial. The environmental condition, temperature, and everything matters. Then we have the procedure name, clinical significance, principle of method, like for the test SOPs and documents should be there. Then using stable control material is very important. Lab purchase good control material, but if it is not properly mixed and it is made into liquids and stored, then we somewhere get defeated in our purpose or our aim. Precautions to be followed, like reconstitute lyophilized material carefully. Please always pay attention towards that. Frozen samples, when you reuse them to run in your machine, be careful that they are properly handled before they are put into the machine, and so on. Using calibrators, don't confuse yourself in controls and calibrators. These are the material of a non-concentration of substance analyte being measured. So they calibrate our machines, whereas internal controls is a daily examination of our overall quality of our man, of our reagents, of our machines, our calibration factor, everything put together is checked by the internal quality control mechanism. And when we go for the third party examination, I call it proficiency testing or EQUAS. These are the different type of QC material available.
We are almost nearing time. We'll keep some time for question and
question answer. So let me move to my few last slides, which I really want to share. We'll not get into this. These are the things that we call. So what ultimately, consequences of poor quality are? Inappropriate action, over investigation, over treatment, mistreatment, then lack of investigation, no treatment, delayed action, loss of credibility of the laboratory, and sometimes legal action. Then new quality initiatives are there. We can apply Six Sigma processes, lean procedures, ISO 9000, and the guidelines of Joint Committee on Traceability in Laboratory Medicine. This is a wonderful document. Please go through it. So to summarize, quality control is a part of total laboratory control program, which comes under the heading of total quality management. Total quality management is responsible for organizational development, for improved quality in all aspects. 5Q are there: QLP, quality practices, quality control, quality assurance, quality improvement, and these quality programs constitute for TQM. And then quality control is achieved through proper documentation, validated intervention of all the three phases. And quality assurance is internal quality assessment plus external quality assessment. When you do these two things simultaneously, your quality is assured at all times. So please enroll and satisfactorily participate in performance evaluation assessment program, establish reference range for analytical being tested, document training and competency assessment for the technicians, provide review and verification of all results released, including verbal results reported. We have to take care of the verbal reporting as well. So I want to share one video here. Please appreciate how the errors are chasing us in the laboratory every day. This, if you are running a lab 24/7, like my lab runs 24/7, 365 days in a year, then this is my condition. Right. So the cheetah here is the errors which are chasing, and the running there is the lab, and the system, quality system, should be as fast as like the man who saved the life. Okay. So take home message here is the last slide: quality is never an accident. It never comes by accident. It is always the result of high intention, sincere effort, intelligent direction, and skillful execution of whatever you have designed. It represents wise choice of many alternatives. There are large number of alternatives in a quality management system, but the wisest choice is the ultimate one. So I have designed one phrase that quality can never be a destination, but it is a continual journey. This is how I understand the quality in the laboratory system. This is how it is depicted, and what Philip Crosby very well said: quality is defined as conformance to requirement, not goodness. We don't have to be good, but it is conformance to our requirement. See the masterpiece created in the sea. So you can read this book on quality, what it says. No matter how good the quality system is on paper, it should be achieved if the theory cannot be translated into practice. It costs, poor quality costs even more. Thank you. And your questions, please. I'm very happy to answer.
Thank you very much, sir, for that very interesting talk. Because when we actually have talks on quality, sometimes it is very difficult to explain it in such a way that people really understand what is that we are talking about. You made the topic very simple, and the large number of interns and postgraduates who are there in today's audience, I'm sure they will appreciate how you have simplified the entire process into something which is tangential. When we keep talking about theory practice gap all the time, like many a times we find that we are overemphasizing on theory, and how we can translate becomes an issue, and we end up falling into those gaps. So I think that was one. And there were two important takeaway messages for me in that particular talk, in the sense I think that your very first statement, what you made, it's not a single man's mission or single man's journey, and it is a collective team effort. That is one very nice takeaway from today's talk. And the other thing which was very, this thing is with regard to quality leadership. A lot of times we keep talking about quality assurance, continuous quality improvement. It looks like as if it is some abstract science we are looking at, but what we are talking about quality is people science. It is more often with motivating and keeping your team together than with anything else. So I think that was two very important things we have. There are quite a few questions. I'll start with one for myself only.
Yes,
You
ma'am.
talked about analysis of errors, and we have a lot of tools. Like we actually are familiar with root cause analysis and FEMA tools for analyzing patient care errors. So how can we apply the same tools in the laboratory? Can you give with an example, sir?
Yes, madam. See, as we said, the laboratory is divided into three phases. So first, whenever you find a non-conformity, when you have to understand that you have the SOPs for everything, and when it is implemented in the area, once you identify, say for example, if I take the hemolysis of the sample or sometime under diluted sample for CBC samples. Okay, this is the right example. You think I could get your question?
Yes, sir.
So if you identify it in the laboratory, then you have to see, observe it, that what are the errors which are happening. Are they using the vacuumized system in the sample collection, or it is a needle syringe system? Then you have to train the person. And once you train them, a training should be followed by the evaluation of the outcome of the training. And then if there is a gap, then we have to change the strategy. Sometimes it is a lack of interest in the person as well. So you know how to motivate that person to do his task. Or another example I will take, that sometimes error happens in the equus sample. When you send a result to a third party and then you get some wrong results, that your result is not acceptable, it has crossed the limit. So lab will not accept it. They, because they feel that they have made a mistake. It is like student teacher relationship. But no, we have to understand that identifying the errors is a very potential and a powerful tool to improve the quality practices. It is not a fault finding mission in any of the ways. Rather, we have to train our people, we have to make them so much acceptable, to agree upon that this mistake has happened. Because when you intentionally do something, it may be in the term of a crime, but it is not intentionally done in our system. But errors are bound to happen. People have to be trained and they have to be given in confidence that once they accept it, they are not going to be punished in any of these ways, but they have to participate in improving those errors so that it never contributes again and again in the system at more cost and can cause somebody's life as well.
Yeah. Thank you, sir, for that answer. So that brings us another question. Now, when we are talking about external quality assurance for our laboratory,
Ji.
what Dr. Bhatt wants to know is how often we need to do this external quality assurance checks.
Sir, external quality assurance is once in a month. It is a third party material, which is, it is like, I simplify this term to our clinical this thing presentations, that we have internal exams in our medical system. Then we have university exams. So university exam is like external quality assessment exam. Internal, we can be biased. I may like some student or somebody known to me, I can give more marks. I can ask simple question to one student, okay, tell me what is the normal range for glucose. And to other student, I may ask much harder questions. So internal controls, there is a possibility of bias, but external quality assessment is like having a university exam or the national level entrance examinations, where the bias is bare minimum, it is 0.0001%. So external, as per the requirement, it is once in a month equus sample we should do, and for every day we do internal quality controls, and the document says every 12 hours we should run one level and level 2, minimum 2 level controls, internal controls. That should be daily practice. Every 12 hourly we have to repeat. External once in a month.
Thank you, sir.
Thank you.
Like, as you said, quality is costly, but non-confirmation to quality must be much more costly. There is another very interesting question in the chat box from Dr. Arun Daniel, Associate Professor, Community Medicine. He'd like to know, how do we address biological errors in quality assessment? Suppose you do a same sample and it is sent to 3 different laboratories. Sometimes you get 3 different results for blood sugar measurements or
Yeah.
serum bilirubin in neonates and all that. So how do we address the standardization of fixing references in this various settings?
Very good and interesting question, madam. It is always happens, madam. I would give you one simple example. Every day, if you are married, the taste of the tea varies from every morning, and we have aaj chai acha nahi bana hai. But this is not something like tea. But only thing is there are different reagents, there are different machines in different labs, and this bound to happen. But yes, there is always, you know, a 10% is the standard variation which is world over accepted, madam. So we have to understand that everywhere, even on the same machine, when I repeat my result, it comes with a minor variation. If in the morning I am running one glucose sample in the fluoride plasma, then it giving 97 milligram, then maybe after 1 hour it can be 95 or it can be 98 or 100. Some variation do occur because what are the factors which contribute to such errors or such changes in the result? The reagent quality might have deteriorated. Sometimes the machines might get a small air bubble or some random error. Random errors can be anything which nobody anywhere in the world can identify, but you can think that this might have happened. So the machine and material changing from different labs can contribute to different results. This normally happens. We call it inter-assay variations even, or intraday variations, or inter-instrument variation, or inter-laboratory variations. But it should be in acceptable limits, not beyond that. It is never acceptable that the patient result comes 96 here and it comes 150 in another lab for glucose. No, there is always a standard practice world over, which say normally 10% variation is acceptable. So this happened. This is because somebody will do on semi-auto analyzers. I give you very interesting example because in our NABL system, we encourage the clinicians to give their feedback or complaints. So from surgery department, we got one complaint that there was a patient admitted for more than 3 months in surgery. His fasting values used to be high and PP2BS glucose used to be low. So they gave us one complaint, we started following, then the result was same. We analyzed the sample again and we say it is same. They sent the sample to some another lab and the result was something different. Then again the issue became crucial that who is more correct, my lab or the other. Then we started sending our resident to the lab rounds. What we found is this patient was suffering from tuberculosis, very fragile, and he was getting regular doses of insulin before his lunch, but he was not eating at all. He barely used to eat anything in the lunch, but insulin dose were properly given. So we did the split sampling. We did morning fasting sample and splitted it into two and sent the other lab and we analyzed. Similarly, postprandial sample also we took and splitted it and sent. The results were almost acceptable, very near about. So the only thing is the insulin was given in the doses which were recommended, but patient was not eating. So the fasting PP2PS was low, fasting was high. So sometimes such errors comes into the mind of clinician, but they have to understand and then we have to do the analysis. And that helps improvement on the other sides, madam. This is how.
Thank you very much, sir. Actually, that brought in a very nice point that if you are talking about quality in laboratory, it's not only the laboratory personnel who are to be there. We also need to bring into the notice of people if the results are unacceptable, and that's how we need to proceed in that. There's one very interesting.
Yeah, there has to be very broader arms by the labs to accept the such feedback or even complaints. Don't mind, but we have to analyze it and see how best we can improve upon.
Yeah. Thank you, sir. There is one interesting question from Dr. Varadaraj Perumal. I think he's your student in MD pathology, sir.
Really?
He wants to know which is good. I don't know what is LJ chart or Six Sigma. So what is that which is better among these two?
Yeah, see, when we have to choose some between the two, initially everyday practices, we must go for the LJ charts because LJ chart is something which we can make a spreadsheet and every day we can ourselves plot our data and we see where do we stand. Because Levi-Jennings charts are based upon when we have our own lab means and we define the level SD 1, 2 and 3 SD limits. And then the next level, when you achieve a very good quality control, internal control programs, it is implemented and you are having a good mean values of your day-to-day control charts, then you go for the next level. So then it is the next level, I should say. First, go for LJ charts. They are very good in practices, and your data is always comparable to your peers as well.
Thank you, sir. I think Varda sir has answered your question. We'll request our Dean sir to give the feedback, questions, comments regarding the talk. Over to you, Dr. Kotu.
Thank you, Professor Mahalakshmi. I don't have any question to ask. It was quite informative, and take this opportunity of thanking Professor Sharma again on behalf of AVMC.
Thank you very much, sir.
Thank you very much.
Okay.
Go ahead.
That finishes today's question answer session. We'd like to thank Dr. Hariom Sharma for taking time to make this topic very simple and interesting for all the people, and also taking all our questions and answering them. Thank you very much, sir. And we have a very interesting talk next week, in the sense that we are going to talk more about quality, but we are going to move to quality in different sphere in a medical education system. So we are going to talk about what accreditations and standards by the WFME, that is the World Federation of Medical Education, mean in education, and why do we need to go for accreditation to improve quality of educational services. And we have the speaker, Dr. Medha Joshi. She is from Bangalore, MS Ramaya Medical College, and she is associated with the International School, where she will be talking to us about standards and accreditations in medical education and how they can help us to improve quality. So that's the talk for next week, folks. Till then, Omicron is there, so you need to have stay safe, wear mask, and follow all precautions, and be kind to each other. We'll see you next week, Friday at 2:45 p.m. Thank you
I'll be
very
happy
much.
to join, madam. Please share the link.
Yes, sir. Thank you very much.
Wonderful activity. Thank you, everyone. Thank you, sir. Thank you, sir. Thank you, madam.
Thank you, sir. So on behalf of Scientific Forum, we'd like to thank everyone for joining us today.
Yeah, thank
We'll
you,
meet
all
you
the
again next
participants.
week.
Yeah, such a good number of audience is there. So thank you very much. I think I failed to thank you. So I want to thank you.
Sir, can this presentation be shared with the audience? There is
Yes, madam.
another request.
Yes. I will send an email. And as quality control is so close to my heart, anytime further discussions, I would be very happy.
Thank you very much, sir. Bye, sir.
Bye-bye.
Bye.